Welcome to another edition of Pancreas School, and I'm really thrilled to have my good friend, Dr. Mandana Kamgar, one of our just incredible medical oncologists, join me for this edition of Pancreas School. And Mandana and I were just talking before we got started today, and we said that we haven't done an episode of Pancreas School devoted to what we call adjuvant therapy, or the treatment of cancer that may be present after we have tried to cure the patient, but it may also may not be present. But in those situations where there is a very high risk that the cancer may come back, there is certainly the compelling logic behind giving the patient a little bit more treatment. And we're going to talk specifically today about a clinical trial that Mandana put together, sponsored by the Sina Mangowitz Foundation, and we'd love to give a huge shout out to the Sina Mangowitz Foundation. We're going to be spending a really fun time with them at American Family Field, the home of the Milwaukee Brewers, this summer in early August, and we're so excited about that. Well, to introduce the topic of adjuvant therapy, it's probably best to go over treatment sequencing in general. So, regardless of whether the cancer is in the head, body, or tail of the pancreas, we're going to assume for purposes of this discussion that it's localized to the pancreas. It hasn't spread anywhere. And we'll just put a timeline here, right across. So this is diagnosis. And I actually spoke, Mandana, to Dr. Tolat this morning, who's chief of abdominal imaging here, a world-class radiologist. And there'll be an edition of Pancreas School on imaging. So that's coming. Stay tuned. So the patient is diagnosed and staged, and we have an edition of Pancreas School on staging. And I'll just put staging is there. And we're talking about localized pancreas cancer, and as you'll see from other editions of Pancreas School, typically they first receive chemotherapy. And Mandana, we typically reassess every 2 months with the chemotherapy. Why is that? Why do we reassess so frequently?
I think one important thing that happens is as we are treating the cancer with the treatment, we want to make sure that our patients are getting the treatment that is most effective. And keeping a close eye on the cancer by those imaging will help us make sure that we are on the right track and we are on the right treatment for that specific patient.
So in general, we think that 2 months is about the right period of time to determine whether the chemo is working or not working.
Exactly.
And even though there are a number of different chemotherapy regimens, and we don't really have the time to get into that, what is the likelihood? So when we give chemotherapy to a patient, the patients know that there probably isn't 100% chance that the chemotherapy will help. But for someone with localized pancreas cancer, so I'd be remiss if I didn't draw the pancreas in here, and it might be in the head, it might be in the body, it might be in the tail. What's the likelihood that we have picked the right chemotherapy for that tumor in that patient?
I think in the context of pre-surgery, what is considered success is rather different to what we consider it for a more advanced disease. So while chemotherapy drugs are very good many times in controlling the tumor, in other words, preventing it from growing, it doesn't always lead into shrinkage of the tumor, which is what we truly want in this setting to increase the chances of a successful surgery and achieving cure. So I would say there is roughly about maybe 1/4 or 1/3 of the times that we can see some shrinkage on the imaging. There is some in between that we really don't see at least much change in the imaging, and probably there is a 1/4 chance or such that we might sometimes see progression or such, many times less than this, but there is still up to that percentage. So I think basically about 3/4 of our patient has at least a stable disease or response, with maybe 1/3 or 1/4 of the total just receiving, really seeing some shrinkage on the image.
A dramatic response.
Exactly.
And I should mention that one of the things that we're all working on is trying to match the absolute best treatment for each individual patient and looking at the unique molecular characteristics of the tumor that may predispose them to the best treatment. So we'll give 2 months of chemotherapy, say it works great, the CT scan looks better, the tumor markers we measure in the blood And remember that we oftentimes measure what's called CA19-9, CEA, and even CA125, carbohydrate antigen 125. We measure all those. Those go down. The CT scan looks better. And we say, gee whiz, that looks great. Let's go with another 2 months of chemotherapy. So we'll put another 2 months here. And then frequently, at this institution, certainly, almost always, we would follow that then with radiation. And from our pancreas school video on treatment sequencing, this will be a little bit of a review. The patients typically then get a little bit of a treatment break, typically 1 month. The radiation may be anywhere from 2 weeks to 5 weeks. And then the patient goes to surgery. I should probably put surgery in a different color. And so the patient then, after their break, they go to surgery and their tumor is removed. This is certainly the best case scenario, what we would like to have happen in every patient. And Mandana, I know this is something that we've focused on in a number of videos, but why do we favor giving chemotherapy first? Oftentimes the patients say to us, well, gee whiz, I can see the tumor on the CT scan. Why not just take that out? We'll just take it out right now. Why is chemotherapy so important as the initial treatment approach for pancreas cancer?
So, Dr. Evans, a lot of times when I'm with our patients, I try to use analogies to just make things a bit simpler. So, thinking of a tumor potentially as a weed in a lawn or in grass field, there are different tumors that grow differently and spread differently. Some tumors really grow locally, they creep and then slowly grow. That's like the weed that is really crawling and growing. Others are those that very early on, they develop their seed and they start to spread the seed. So their seed goes into the soil elsewhere. So while looking at the lawn at that time, we just see it in a certain area. The chances are that the seed is in other places and it will grow. So pancreatic cancer is very much like the seed of it in other soil of other organs, meaning it from very early stages, although on the imaging we might just see it in the pancreas, it has the tendency to spread its seed in the soil of organs like liver, like lung. They are too small, we can't see them, but if unattended, they can grow and they can develop new spots of cancer. So we call them micrometastases, small areas of a spread that cannot be seen on the regular CT scan or PET scan that we use. And the whole idea of using chemotherapy is to use some of our best available options earlier on to try to get rid of these spots that might be outside of the pancreas already, so that hopefully by the time that the surgery is done, the chances are that there's nothing left behind and our patients are cured from the cancer.
So one of the reasons why we think that this sequence, chemotherapy, radiation, and surgery, is better than surgery followed by chemotherapy with or without radiation, is that the little cancer cells, if they do exist outside the pancreas, they're more likely to be destroyed.
Correct.
Chemotherapy is probably more effective when the number of cancer cells is really small. Some people think that that's due to the lack of resistant cells within those tiny little foci of tumor. The chemotherapy is more effective. So chemotherapy, radiation. After surgery, the tumor gets sent to pathology. The pathologists generate a report. And there are a number of things that we look at on the pathology report. It typically comes back in a week or two after the operation. They give us the tumor size. And we pay specific attention to the lymph nodes. And the lymph nodes are adjacent to the tumor. They're actually manually removed by a couple really talented physician's assistants in pathology. They're cut in half, they're stained, they're looked at under the microscope, and the lymph nodes will be reported as either positive or negative. So after undergoing all of this treatment, we can kind of dichotomize patients into those who have all great results. Their pathology shows negative lymph nodes. The chemotherapy and radiation has sterilized the lymph nodes in the tumor. Their tumor markers that we measured here are all normal. And in general, those patients, we would say, probably don't need any additional therapy, right?
Correct.
However, that we would love that to occur in every patient who undergoes chemotherapy, radiation, and surgery, but that unfortunately is not the case. Some patients, even after undergoing all this treatment, their tumor markers may be elevated. They may have 1 or 2 positive, maybe 3, 4 positive lymph nodes. And with information such as this, the likelihood that the cancer may come back over the next year, 2 years, 3 years, 4 years starts to go up a little. So for those patients, Dr. Kamgar created Protect Panc with the aid of the Sina Mangowitz Foundation. So I cleared a little bit of our whiteboard off so we can now talk about the situation where the patient underwent chemotherapy, radiation, little break, surgery, and then we typically reset and reevaluate anywhere from 6 to 8 weeks after surgery. And at this point here, 6 to 8 weeks, we typically get another CT scan. We review the pathology. We check the tumor markers again. CA19-9, CEA, maybe CA125. Here at MCW, at about week 3, we also send a test called Signatera, which looks at circulating tumor DNA in the bloodstream. And then we also look at molecular profiling or the mutations in the tumor. So I'll just put tumor mutations here. And Dr. Kamgar will explain this. So Mandana, I think everyone watching this video understands that at 6 to 8 weeks after surgery, we redo the CT scan, assuming the patient's feeling okay. We have the pathology report with the, I'll just put alpha lymph with the lymph nodes. We have the tumor markers from a blood test. We look at circulating tumor DNA and then the mutations in the tumor. So Mandana, maybe you could explain these 2 items. First, circulating tumor DNA.
Sure. So, Dr. Evans, the good thing is that recently or over the past few years, there has been much improvement in the tests to evaluate the tumor at much, much smaller sizes. One test is the circulating tumor DNA, which is technically trying to find the cancer in very small quantities at a time that it might not be visible, but it's shedding its DNA in the blood. They can differentiate the cancer DNA from the normal DNA of the normal cells. And in general, it is a test that if after the surgery we check it and we see that this is positive, it's very much predictive that there is some cancer left behind and that we would need to do something about it to prevent or decrease the chance of it coming back.
And this is certainly an evolving technology, this circulating tumor DNA. Right now, the test that you tend to use more frequently is Signatera.
Correct.
But there also are a number of other tests that can be used, and this oftentimes is reported as simply positive. In other words, it looks like there are some fragments of DNA from the tumor still circulating in the blood, or it's reported as negative.
Correct. They mostly also tell us what fraction of the DNA that they find is cancer DNA. They don't, in this Signatera test, they don't tell us what exact mutation they found. They make a personalized panel of genes to really try to find that cancer in each patient with the highest sensitivity with the highest likelihood of finding really tiny spots. And what they do is they try to see whether they can find that specific cancer in the body or not. And then they give us a load of how much of it they found in the blood as well.
The technology is just amazing. And it's rapidly evolving, just improving all the time. So we have circulating tumor DNA, and then we have the somatic mutations, or the mutations that are unique to an individual patient's tumor. So tell us about this. This is something that has been evolving over really the past decade. And now what happens is the tumor we take out in surgery goes to pathology. The pathologist use a fair amount of that tumor. They make slides and various cell blocks to create their report, which gives us the tumor size and the status of the lymph nodes. And then it is actually sent off at our institution to another company. And there are a couple companies that do this for patients throughout the United States and throughout the world. And they then report on the genetic mutations in the tumor. How would you explain that to our lay audience here?
So, Dr. Evans, I think I have to step back and talk a bit about normal cells, how they get the information, and briefly how the normal cell become cancer. So, in general, our body is composed of some building blocks, which are called cells. Each cell has a unique function, and together, hand in hand, these cells work to make sure our body goes on and we stay alive and go on. So the information for each cell comes from a book that contains all the orders that really have the code of conduct, what to be done, what not to be done. And this book is structured in chapter, each chapter really dictating a certain function. That book of orders is the DNA, and those chapters are the genes in the DNA. The cancer happens because in the process of this DNA from an old cell getting handed over to another cell so that our body maintaining itself, a misspelling or mutation happens. So the orders that goes to the next cell is wrong. Many times this first misspelling happens in a gene that dictates growth, a gene that was supposed to tell the cell grow, stay stable, and now you're old and you have to die, becomes active all the time. That is the earlier stage of cancer. That is like a polyp in a colon, a precancerous. And as these cancer cells divide fast and fast, they acquire more and more misspellings. And eventually a combination of these can lead to the cancer, which is the aggressive form, grows, spreads. And each patient might have a unique combination of these misspellings, meaning that the drivers of the tumor, the strengths and weaknesses of the tumor in each patient is different. And the only way to really know that is to really check the DNA of the tumor, run it, and see which misspellings we find in which chapters of the
So well said. So we may have anywhere from, say, 3 different mutations, and our audience is probably familiar with KRAS, P53, and various others. There also may be 5 or 6 mutations in the tumor. So if, for example, we had a patient where despite our best efforts at chemotherapy, radiation, and surgery, everything went perfectly, treatment was well tolerated, there were, say, 4 positive lymph nodes out of maybe 30, and the CA19-9 in the blood was still elevated, and or there was evidence of circulating tumor DNA, we would say that patient is at increased risk for the cancer coming back at some point in the future. Correct. It might not be for a year, it might not be for 2 years, but while the cancer cells are small, now is the time to go after them.
Exactly.
And therein lies the logic behind the Protect Panc trial. So this is a clinical trial for those patients who have completed all intended therapy to cure their pancreas cancer, and the information we get back at 6 to 8 weeks is not as rosy as we would like. So in this clinical trial, how does the patient get treated?
So with the knowledge of each patient's mutation, we potentially have options to focusing on the drivers of the tumor in that patient and how we can prevent those from basically feeding the tumor, from making the tumor grow. In order to really find the best potential option, we take these mutations to a tumor board, which consists of physicians, pathologists, basic scientists. We discuss all of the potential mutations or other drivers of the tumor, and we try to see among the medications that we have at the moment, what combination will be the best option for this patient. In other words, we are trying to really come up with a personalized treatment for that patient, which hopefully has the highest chance of controlling the tumor because truly it's designed for that patient and for that specific tumor in their body.
So these are medications which are tailored specifically against these mutations which are in the tumor. And then the novel aspect of this is that you're combining them together. Mm-hmm. So how do you know what doses to use when you're combining these drugs that in some cases may not have been combined together before?
Mm-hmm. So the studies that normally are done, they determine different dosages of the drugs. One certain dose is that the dose that most of the cells respond to it. The other dose is at the maximum dose that our patient could tolerate. Majority of the studies are designed to use that maximum dose, but in reality, we can use lower doses of the drug to get the response. And specifically, when we combine them, they help each other, so we need less dose of each drug. So normally, we start with about 50% or such of the dose of each drug in combination. And then depending on the tolerance, we can always adjust the dose further, increase, decrease, and based on the tolerance and based on how the tumor is responding.
Yeah, so well said. Couple of points to emphasize. Number one, this is a clinical trial, which means if you're enrolled on this clinical trial, every aspect of your care is checked, double-checked. Clinical trials provide a level of safety that is just so important for patient care. It's not just you and me who are caring for that patient and watching them. We have a host of others between research nurses, radiologists, pathologists, everyone to make sure that the treatment is extremely well done safely. And second of all, patients can receive their chemotherapy, radiation, surgery anywhere in the country, even outside of this country. And then they can be referred here for consideration of the Protect Panc adjuvant trial. So adjuvant, treating patients who have possibly cancer still in place, but we can't see it on any scans. We're concerned about it because of the fact that they may have had positive lymph nodes, they may have circulating tumor DNA that is evident on testing, they may have elevated tumor markers in the blood such as CA19-9. This is really a remarkable trial. It is cutting edge. It brings the newest possible therapies that are being developed really every month, every few months in the United States and throughout the world, and it brings them to the bedside of the patient. They typically receive this as an outpatient. Mm-hmm. It usually involves a little bit of time in Milwaukee at the beginning. Mm-hmm. And maybe you can explain that as the conclusion of this episode of Pancreas School, why at least a little time in Milwaukee at the beginning of the trial is needed.
Yeah, Dr. Evans, so as you mentioned previously, while these medications are already tested in other settings and they have got approval, we know their side effects, they are truly being tested in this study sometimes for the first time together. So one thing that makes us want to be more cautious to monitor the side effects is the combination of them. The other thing is that each patient or each person is really different from the other. What one can get of the side effects is very different from the other person. So we want to make sure before we send our patients back to their home that we know that the right dose, that we know that there any side effect that has happened, we have managed it, so that when they go home, hopefully they will be able to just continue it with some phone visits, labs locally, and they just can come here once a month or such to see us, and then we follow and make sure everything is going well and the tumor is controlled and that our patients are still tolerating it well. There's one thing, Dr. Evans, that I really wanted to emphasize about the novelty of this study. So we talked about how much our technology has changed in finding tumor DNA, in finding the mutation, and it's expected that this technology will continue to improve. Same is true for our treatment options. Every month, as you said, newer drugs will come. So what is specific about this study is that the decisions that might be made a year ago might be different from now, might be different from a year later, meaning that at any given time we use the latest technology available to us, the latest medications available to us. So as the months and years pass, if the study is open, the study will not be outdated because we will catch up and we will keep up with the innovation and with the progresses in the care and in the medications that come for the cancer in general.
Absolutely. A clinical trial just means that we hope this will be the best possible treatment. It's the treatment that we would want for ourselves, and we're trying to prove it. In this case, as the technology improves, the clinical trial adapts all that new technology. As you said, it doesn't get stuck in the mud. It keeps going 90 miles an hour down the highway. So Dr. Kamgar, thank you so much, Madonna Kamgar, and please see her other videos on Pancreas School. They're fantastic. A huge shout out to the Sina Magowitz Foundation for sponsoring and supporting the adjuvant trial open here at the Medical College of Wisconsin, referred to as Protect Panc. Thank you all for watching today.